So we can go.
It's my pleasure to present speaker, Dr. Aikaterini Tzantzaroudi, who is a pediatric oncologist in pediatric surgery clinic Hippokrateion. She will talk about pediatric sarcomas and the role of surgery. So, good afternoon to everyone.
Όχι, εκεί μόνο, γιατί είναι σε παιδιά. Όχι, δεν είναι σε παιδιά. Οπότε πρέπει να κοιτάξετε εκεί. Να προσπίσουμε. Δεν μπορεί να πέσει το στόχο. Μπορεί να σου πέσει και να το δείχνουμε. Οπότε τι να το κάνω. Αν θέλετε να κάνει μια εισαγωγή, θα σας το.
So the topic of my presentation is actually the role of surgery in pediatric soft tissue sarcomas. I will try to be brief. So, this is the case. You think this one? Okay. So let's start with some basics. Soft tissue sarcomas are relatively rare tumors in children. For example, in the USA, less than 1,000 children, adolescents are diagnosed each year with these tumors. They can be classified in two major categories. The rhabdomyosarcoma group, which is most common in children younger than 14 years old, and also the non-rhabdomyosarcoma soft tissue sarcomas, which are more common in adolescents and young adults. We can also see these tumors, the non-STS tumors in infants, and for example, we have the infantile fibrosarcoma and also the malignant hemangiopericytoma. So let's see some things about the rhabdomyosarcoma group. It consists 50% of all soft tissue sarcomas in children younger than 15 years old. It has an incidence of about 4.6 per million per year, and this incidence has been steady over the last 30 years, and has a bimodal case, with the first peak being at about 2 to 5 years old, and the next peak to 15 to 19 years old. And it is seen slightly more common in boys and girls, and also more common in the Caucasian children. Rhabdomyosarcomas actually can be found anywhere in the body, but this has a great importance because its location has its own prognosis. Regarding etiology, no? Yes. There has been an association with some syndromes, such as the Lee-Fraumeni syndrome, neurofibromatosis, and also Beckwith-Fiederman syndrome. And also there has been a weak association with congenital anomalies, especially genitourinary anomalies, especially in boys. In many of these tumors, we see gene mutations and also chromosomal abnormalities such as translocations, gains, and losses. And sometimes these tumors are seen as second malignant neoplasms after radiation therapy. And here we can see some chromosomal abnormalities, not only in the RMS group, but also in the non-RMS group. We can distinguish four different histologic types of rhabdomyosarcoma, with the most interesting being the embryonal subtype, which presents in 60% of the cases, and it appears with a favorable prognosis, whereas the alveolar types presents at 20% of the cases, and it has a worse prognosis. Something very important for these tumors, as in all tumors, is the staging. So here we have the TNM staging system. This system takes into account the site of origin, the extension of the tumor, the size of the tumor, greater or smaller than 5 centimeters, the presence of lymph node, and also the presence of metastasis. And here we have another grouping system, a clinical grouping system, which is encountered by the intergroup rhabdomyosarcoma study, and it is based on the resectability of the tumor. So we have group 1 with localized disease completely resected, group 2A with gross total resection with microscopic residual disease, group 2B with regionally involved lymph nodes completely resected with a primary tumor, 2C, regional disease with involved nodes, totally resected with microscopic residual disease, or histologic evidence of involvement of the most distant lymph node in the dissection. At group 3, we have incomplete dissection of the tumor, and at group 4, we have distant metastasis. The risk stratification in rhabdomyosarcoma actually is based on the histology, the clinical group, the TNM stage, and we have 3 different risk groups from low, intermediate, and high according to these stages. So what is the role of surgery in rhabdomyosarcoma? So we have seen that the clinical grouping of the patients is very, very important in determining the treatment and the prognosis. So the surgeons should stick to specific surgical principles. And of course, the basic principle is that of the radical resection of the tumor with tumor-free margins. But this principle in children should be followed as long as sacrifice of surrounding normal tissue does not result in unacceptable loss of function or if it is not feasible. So if we cannot perform a radical resection, we may need to have an biopsy. And in this case, an open biopsy is indicated. It can be excisional or incisional, and in some cases, as in genitourinary RMS, we can have an endoscopic biopsy. If the initial surgical procedure is a biopsy or an unplanned excision, for example, for a tumor that was considered non-malignant, then the question of primary re-excision often arises. And in such cases, what we should do is wide re-excision, unless this results in unacceptable loss of function or an unacceptable cosmetic result. Simple excision, which means re-excision before the start of chemotherapy, results in lowering the clinical group and, of course, has a more favorable prognosis. So, one primary local treatment modality is local radiotherapy. We have usually residual persistent mass, but this mass is not associated with patient outcome. For that reason, secondary surgeries are not routinely recommended. Another key point is the presence of positive lymph nodes, and because this has a direct impact on the extent of the radiotherapy. In most of the extremities, the children's oncology group currently recommends aggressive regional lymph node sampling. In general, prophylactic regional node dissection is not recommended, but in boys with parotesticular RMS, staging ipsilateral retroperitoneal nerve sparing plate node dissection is required for all boys older than 10 years of old, and also in patients younger than 10 years of old who have radiographically positive nodes. And here we can see that through successive clinical trials, such as the IRS IN2-4, there is a steady, constant improvement in the survival of these patients, with current estimations being about 75%, in overall all stages. And a few things about the non-abdominal sarcoma, soft tissue sarcomas. According to the International Classification of Childhood Cancer, we have 4 different categories: the fibrosarcoma category, the Kaposi sarcoma, other specified soft tissue sarcomas such as the synovial sarcoma and the extraosseous Ewing sarcoma, and some unspecified soft tissue sarcomas with less clinical importance. The histologic subtypes of the non-RMS group actually comes from is based on the normal tissue that derive from. So we can have these tumors coming from the fibroblasts, the Schwann cells, the blood vessels, the adipose tissue, the smooth muscle, the synovial cells, the blood vessel pericytes, and also chondrocytes. And as we can see here, the incidence is very low. The risk stratification in non-RMS tumors is based on the grade of the tumor, the size, the state, if there are any metastases or not, and the initial resectability of the tumor. And based on this risk stratification, the oncology group, the pediatric oncology group, has proposed a treatment plan after surgery, which in some cases can be just observation, or in some others, we can have adjuvant radiation therapy, chemotherapy, or even an additional surgery. The role of surgery in non-RMS, a biopsy. A biopsy is very crucial in order to establish the diagnosis. The diagnostic procedure of choice is the core needle biopsy, because in most cases we can have adequate diagnostic tissue. It has an excellent accuracy, high sensitivity and specificity, and low morbidity. These biopsies should be obtained always by a trained surgical team, and ideally at the multidisciplinary sarcoma treatment center. And something very important is that the site of the biopsy should be chosen so that it lies in the field of the resection. If a core needle biopsy fails to set the diagnosis, then we can have an open biopsy. So in non-RMS group, surgery remains the cornerstone of the treatment, and the goal of our surgical excision is the complete removal of the mass with a 1 to 2 centimeters margin of normal surrounding tissue. And if we have closer margins, we should really think about strongly of re-excision. So when we do not have complete, or when complete tumor resection risks compromising the integrity of distal structures, then we can have adjuvant chemotherapy or radiation therapy. And finally, amputation should be reserved nowadays only for cases of major artery or nerve involvement, sufficiently excessive bone involvement, or recurrence after previous resection with adjuvant radiation therapy. In a few words, oral surgery for both RMS and non-RMS tumors is becoming less mutilating. The surgeon continues to play a critical role in initial biopsy and staging, the primary excision, the appropriate wide local resection. Therefore, the surgeon should be an early participant in the multimodal approach to treatment. Thank you very much for your attention.
Thank you very much. It was a very good presentation, and you gave us the basic rules in pediatric surgery in oncology. We know that there are many problems. Sometimes we have dilemmas, but this has to be examined personalized. Is there any question from the audience? Okay, thank you very much. Thank you very much.
Have a break, coffee break for 15 minutes, okay?
Yes. Just 1 more minute, please.
Yeah, here closes the session in this room, but I just wanted to remind you that in the main auditorium, Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.